Dr. Malika Fair is the Senior Director of Equity and Social Accountability at the Association of American Medical Colleges. Dr. Fair develops programs and initiatives with multidisciplinary partners and local communities to advance equity, racial justice, population health, and accountability in academic medicine. She is also an Associate Clinical Professor of Emergency Medicine at the George Washington University School of Medicine and Health Sciences. Dr. Fair completed her residency training and chief residency at Carolinas Medical Center, received her medical and Master of Public Health degrees from the University of Michigan, and a Bachelor's of Science from Stanford University. Dr. Fair.
Good morning, everyone. I was talking to my colleague, Patrice Kane, who's our Director of Racial Equity and Public Health at the AAMC, about how excited we are to be here today. Excited that we are one of the supporters of this symposium. And unlike other meetings where we can go and attend or we are putting on the meeting, this is a learning meeting. This is a meeting where we're working, we're learning with all of you. We're trying to understand what some of the challenges are within all of your medical schools, with your students, with trying to be an anti-racist institution and how we can best support you. So even though I'm speaking today, I hope that you all will give us something when we leave here, homework to do at the AAMC. I'm sure you'll have no problems doing that. But before we do, and let's see if these slides are here, I'd like to tell you a story about my clinical experience a few years ago. I was sitting in the emergency department and I got a radio call from our paramedics and an EKG showed up on my screen. And as some of you who know, sometimes our EKGs will have a reading on them. And this one said NSTEMI, or non-ST elevation MI. And I thought to myself, okay, perhaps this could be a myocardial infarction or heart attack, or maybe not, but let's see what we're gonna do about it. My resident looked at it and he said, I don't think we need to call anybody down about this one. But the paramedic on the phone sounded a little bit concerned and said, I don't think this patient is doing well. So I think you should take a look at him. So I called our cardiologist, I called the whole team down, and no one was happy about this call. Okay, it's in the middle of the day and they've got things to do. And I remember we were standing on one side of the emergency department. So we've got the cardiology team, you've got the ER residents waiting for the patient to come in with the paramedics. And in rolls in an African-American male who was in his mid-30s. He was lean, he was muscular, and he did not seem to be in distress at all. And I remember the comments. Here goes the ER again, overcalling this EKG, and we'll just run some tests and get back upstairs. But they were down there, so let's do our job. So the patient rolls into the room, they put him on the monitor, they get his blood pressure, and the blood pressure is about 180 over 110. Didn't seem quite right. I got some blood tests, and the blood tests were not normal either. And they said, well, maybe there's something going on. We're down here, let's just take him upstairs to the cath lab and see if there's something going on. About 30 minutes later, I got a call that one of his main arteries, his left anterior descending, was about 100% blocked, or maybe 99%. They put in a stent, patient did well. And my resident came up to me afterwards and said, Dr. Fair, what happened there? The paramedics were concerned, you seemed a little bit concerned, but nothing, when we saw him, we just didn't think anything was happening, and he clearly had disease. And I said, well, this is an example of racism in medicine. This is an example of bias where we saw an EKG that was concerning. We heard a story that was concerning. And as soon as we saw the patient, we immediately dismissed him. He absolutely could not have heart disease. There's no way that someone that looked that comfortable, who was that young, that muscular, could be having a heart attack today. And so we had a conversation about this. And I said, you have to understand that we all come in with these biases. and that racism, as we heard from our previous speaker, is part of medicine. And I want to show you this slide that I borrowed from a colleague who presented at our group on diversity and inclusion last week in Palm Springs, and I have no financial disclosures, but these are my biases here. This is my background. I'm Black American. I'm descendants of enslaved people. I won't read everything on here, but I am a physician. I've spent my life doing work in diversity, equity, inclusion, and health equity, both in the emergency department and in the AAMC. And I'm also a widow. And I told this, my residents knew this, but I told them that day, and I said, one of the reasons why I was particularly sensitive in this case, because my own husband died of something very similar. And they were taken aback. And I said, even though this is an example of what we see right now as racism in medicine, my own positive bias was able to recognize what was happening in this patient. So I'm going to give you a moment. Take a look at this screen. And as you see, I'm also have from a Pentecostal Christian background. My parents are preachers. And so I'm going to ask you to turn to your neighbor and tell your neighbor one thing on this slide for you that is your bias. Maybe it's from where you're from in the country. Maybe you're from the Bronx that we heard such wonderful things about today. And how could this impact either the care that you provide or the care that you've received? And so we'll take a moment to do that. So turn to your neighbor. All right, we'll take one more minute.
That's one of the more challenging ones for me because it's complex than most of my others where I sort of know what direction or what the spots studied, Christian history, so I have sort of dual biases, like to sort of hard, but also like a good the position sometimes I feel
So I'll refrain from asking you all to say amen.
sometimes it also is like a bias, oh, that just like cringe the wrong way to say that. And, so it's hard for me because I don't always know. It's like, it's like, because it's being at the same time. I do really, especially as it makes your sense. Right. But it's I find it really challenging. So I respect that and then it's really
I know we could keep talking for a while, but I ask that you wrap it up real quick. And if we could advance to the next slide, please. I hope you learned something about your neighbor. I hope you learned something about yourself. And if we could go to the next slide, please. So this is again another one of my biases. I've practiced a long time, and this image is from a Cerner electronic health record. But maybe you all have a similar experience for the clinicians in the room that walk in, You sit down and you have your list of patients that you're going to see this today, and this is from a typical emergency department, where you see the names of your patients, their chief complaint, what they're waiting on, how old they are, their vital signs, and maybe even a little icon on the side. And hopefully in your discussions, you described your own personal bias or maybe experiences that you've had. But I can tell you, when I look at this image, it's a little bit triggering for me because I remember conversations that I've had where you see the little icon with an interpreter and it's that groan. They say, oh, I've got to wait for the interpreter to come. Or you see a last name that you can't pronounce. And you're like, oh man, I wonder if they're going to be compliant. Or you see a chief complaint of an illness that may be associated with a certain race or ethnicity. And you think, oh, I'll go see them in a few minutes. I'll just put in some orders. And I used to think this was anecdotal, that people who had this mind of health equity and D&I, we would just talk about it when we were practicing. But if you could go to the next slide, I was really impressed when our colleagues at Rush University published this study where they looked at their patients, almost 18,000 patients in their health system, and they documented all the negative patient descriptors that were showing up in the electronic health record. That Black patients were 2.5 times more likely to have something negative written. And as you know, this is copied and pasted multiple times in the electronic health record. Now, I'm talking about what's happening at the bedside and in clinical medicine, but it doesn't just start there. It starts as soon as we show up. It starts on day one in medical education. If you can go to the next slide, this image here, not this one, the next one, maybe. Next slide, please. But the image that you'll see is from my colleague in Washington, D.C., Dr. Lisa Fitzpatrick, a primary care physician based in the district. And I saw this and I asked her for permission to use it because she wanted to show her patients who are brown and Black, who said, we want to be able to understand our anatomy, but she wanted an image that looked like her patients. But she couldn't find one. So she had to have this one made. And I think that this is striking because I never saw an image like this in medical school. Maybe you did. I hope things have changed. But when you don't see images that look like you or who look like the diversity that we're taking care of, what does that do to your practice of medicine? And if you go to the next slide here, I was floored, and I know this has been talked about already. I was floored when this paper came out in 2020. Many of you, I see some nodding heads here. We've been practicing for a while. We've been using these algorithms, and they put it all together and showed that most of us, all of us, and definitely medicine, that we were perpetuating inequities by using some of these algorithms that had false assumptions embedded in them, racist assumptions embedded in them. And it was a call to action. Now, we at the AAMC, we've been talking about this. We've had sessions. We've invited many of you to talk about this race correction and having race in clinical algorithms. But I was struck even more when I learned that even algorithms that don't have race at all are also perpetuating inequities. If you go to the next slide, this is another landmark study that came out in 2019, which looked at algorithms that are predicting who are the patients who are going to need high intensity care, that case management. When you have someone who has a lot of chronic conditions, you want to be able to identify who they are, get those wraparound services, and make sure they're connected so they can have their chronic conditions managed. For the public health folks in the room, the population health management folks in the room, this is what we love, right? This is how we take really good care of our patients. But 100 million patients in the United States are subject to these algorithms that were biased against Black patients. Because there was an assumption that if you have cost the healthcare system a lot in the past, that you will continue to cost the healthcare system a lot. And if we can identify those high-cost patients, then maybe those are the ones that we should be providing these wraparound services. But the assumption was false, because Black patients who are just as sick as others don't actually cost the health system as much because of poor access to care, mistrust in the health system, barriers to getting access to some of these high-cost procedures. And because of that, you had to be a lot sicker to qualify for these wraparound services. So what this did is it caused a lot of people to question, why are all these algorithms, the rule-based ones that we're using at the bedside, the ones that are involved in artificial intelligence, why are they contributing to health inequities? Why is there bias baked in, and what can we do about it? If you can go to the next slide, a letter was sent from Congress and HHS was called upon to do a national study to figure out how we can analyze and come up with recommendations to eliminate bias, racial bias specifically, from our algorithms in clinical medicine. This is one of the first papers that will come out, and there will be a series of other ones. But essentially, a request for information was sent out in 2021. Several organizations, I'm sure many of you were submitted to this, and AAMC did as well. And this one that just came out in June essentially states that algorithms use and bias should be discussed between clinicians and patients who are often unaware of their use and potential for bias. Clearly not this room. You all are very much aware of bias. But mostly in medicine, we don't know about these algorithms. We don't know why that there's bias that is embedded, and we don't know what to do about it. So if you can go to the next slide, the rest of this conversation is to do just that. We won't talk about the entire broad swath of how to remove bias from algorithms, but we will talk about what is our role as medical educators, as clinicians, as learners. What are 4 things that we can walk out of here today and address bias broadly and specifically within clinical algorithms? If we can go to the next slide. Now, in case I've already lost you and you want to check your email, I'm totally fine with that. But if you want to, you can get out your phones and Google DE&I competencies at the AAMC. If you do that, what you will find is you go to quick downloads, and you can scroll to the very first diversity competency. And I'd like you to do that if you have a moment, and then you can follow through the rest of these slides. But we're really pleased at the AAMC over the last few years that we've had an opportunity to put out several competencies that have health equity baked in, and the most recent being our diversity, equity, inclusion competencies. Because we feel that this is one way, in a non-prescriptive way, we can develop conversations, do a gap analysis, and assist each of you in developing curriculum that is focused on advancing health equity and addressing diversity, equity, inclusion in our medical schools. And if you can go to the next slide, please. So these competencies were not created out of thin air. They were connected to existing milestones, EPAs, and the competencies as part of ACGME. And therefore, all levels of learners. So what we expect from medical students when they graduate from medical school, what we expect from residents when they are about to finish residency and go on to practice, and then what we expect from our physicians who are in practice about 3 to 5 years. And if we could go to the next slide, I'll go through one example here. So this is the very first competency that you will see if you go through the document. And hopefully this describes the story that I talked about, that we start with self-reflecting on our own biases, our own experiences, and how it might impact the care that we are providing. But we can't just think about it. We have to do something about it to mitigate those biases, to acknowledge what I'm going into the room with, and how do I make that adjustment right there at the bedside. And that's what we expect from residents. And then how can we role model that to our learners? Can we engage in that conversation that I had with my resident and say, what can change next time? And that's what we expect from our faculty members. If you go to the next slide here. Now, many people are looking at these competencies and say, is this a checklist? Can we just check everything off and say that I'm ready for the next level? Or can I use this as an assessment tool? It's not that, but what it is, it's meant to start conversation. It's meant to have all of you look at your curriculum, look at your course materials and say, when my students finish, Have I hit all of these? Will I be able to teach these competencies? And for our learners and for our residents, it's not a self-assessment tool, but something that you can look at and reflect and say, where can I challenge myself? What we found when we had feedback from over 200 individuals, and several of them who are in the room today, is that many of our students are actually more advanced than our faculty members, and that we all have a lot of learning to do here. So don't feel bad if you find yourself in that medical student category, but I think it should challenge us all as clinicians, educators, and as learners. Next slide, please. So let's move into what is our role. We're going to go over 4 different competencies, and this is not exhaustive, but after 4, I think everyone tunes out. So we're just going to do 4 today. The first one, next slide, please, is D4. And this is, how do we advocate for policies and practices that promote, build, and sustain the diversity of the healthcare team? If you go to the next slide, it's just a colorful image here that reminds us, and I don't think I need to tell all of you, the importance of diversity. We know that it improves access to care, improves patient satisfaction, and the citation on the slide here is one of my colleagues at AAMC that published the paper that shows that when you have Black physicians, you have minoritized physicians in the area, that it actually improves your life expectancy. Next slide, please. But what was really interesting, and maybe you all have heard of this podcast, I thought it was really fascinating storytelling from Trade-Offs. But what they did was they highlighted a story at Duke Medical Center, and 2 colleagues were working on an algorithm to identify sepsis in children. Now, we all know that that's a challenge, and we don't want to see anyone die of sepsis, especially not little kids. And so they came up with this painstaking process to come up with an algorithm to diagnose sepsis really early. And these were conscientious researchers. They acknowledged bias. They said, we want to check every step of the way and make sure that we're going to look for race, ethnicity, and making sure that there's no differences. And they felt really good about it. And then a new team member joined, who was a global health fellow. And she said, well, this is fantastic that you've got your vital signs and you have the blood tests and it's going to diagnose sepsis, but have you accounted for your Hispanic patients and their blood tests are going to come later because they're going to have a delay in getting their initial blood work? And they were shocked because they thought about this the whole time. And they said, we were going to make sure that we are not going to have a biased algorithm. And one of them described, and I would listen to the podcast, he can tell it better than I can, but he put his hand over his face and he said, but we tried and we didn't even think about it. We didn't think that waiting for an interpreter, waiting that there's a bias and a delay for Hispanic patients in our emergency department, and the system, so the artificial intelligence algorithm is being trained to think that Hispanic patients are less likely to become septic or that there's a delay. So I bring this up because we all have a responsibility, not just to have a diverse healthcare team at the bedside, but in every aspect of our medical center. We have to be involved in these studies. We have to be part of reviewing the algorithms. We have to be on those committees where a new algorithm is showing up in our electronic health record. And we have to advocate for a seat at the table and be part of these discussions so that we can ask those questions early and often. Next slide, please. I'm sorry that this is cut off a little bit, but the next example is about quality improvement, which all of our learners at some point have to have a quality improvement study, part of residency, and a lot of our faculty members are involved in it. But oftentimes, quality improvement does not have a health equity lens. I don't understand that, but this is something that seems to be left off of quality improvement in academic medicine. If you can go to the next slide, you'll see a historical report that I wish I could just put up on the slide and say, remember when? Those days back in 2000 when things were really bad? And unfortunately, I can't do that. This study showed that even when you account for all the socioeconomic factors, that we provide different care across race ethnicities in our hospitals. And the next slide shows that things haven't changed. These data are from the Agency for Healthcare Research and Quality, and you see from 2000 to 2019, what's yellow on the slide here is unchanged. There's a little bit of green to show that maybe some improvement. This is not what's happening in health in general. This is healthcare. This is in our hospitals right now. If you go to the next slide, it starts in medical education. This paper is from our colleagues at Boston University, and they published this framework of how to address racism in medical education. It starts with the cases that we provide to our students and how we can examine or should examine the use of race in our clinical vignettes, diversifying our clip art and our medical images, and critiquing the strength of evidence in our race-based medical practices. These are just 3 of their recommendations. But if we don't start on day 1 in medical school, we won't be able to identify and address these inequities going forward. And then if you go to the next slide here, and I can make these slides available if that's helpful. These are my colleagues at University of Michigan who knew, just like all of your health systems, that there's a lot of data coming in. But they asked the question, how can we stratify by race ethnicity to see if there's differences right here in our emergency department? And they wanted to know, are their patients being seen when they walk into the ER at a different time? So are there Black patients being seen later than their white patients? What about the time to their first dose of pain medication? The time to their second dose of pain medication? The time to their ordering of a CAT scan? And they found differences. And they were able to say as a department, we see that there's differences in how we are taking care of different races, and we're going to come together to address those inequities. Next slide, please. So our third competency is around community, making sure that community voice is heard. And I'll read this. Collaborating with diverse interprofessional team within their system and with community members to meet identified community health needs. And if you go to the next slide, I think it's no surprise to any of us what happened in our nation in 2021 when our vaccine was available for COVID-19. And there was clearly our health system, our public health system had not been trustworthy. And so there was hesitancy in the uptake. And we brought up a lot of historical factors of egregious actions on behalf of the medical and public health community. And this is not just relevant to COVID-19, especially as we're discussing bias in algorithms, both the rule-based ones and artificial intelligence. We have not engaged our local community. Our patient voice has not been heard. Even in the example that I just told you, they could have found out earlier if they had asked their patients, what else could we be missing here? What could be influencing your care that we have to incorporate into this algorithm? If you go to the next slide, this is an image of an example of how we can engage our patients, not just at the bedside, but in forums, in small focus groups. But our community voice has largely been left out. And for the learners in the room and for the faculty members, if you go to the next slide, this is a reminder, and I know for the public health department here, and if you could click one more time, these are the 2 community health needs assessments in the District of Columbia. One is from our health department, and the other is from the academic medical centers that have come together to do their joint community health needs assessment. And I like to include this because oftentimes this is not part of medical education. It's a separate office, it's a separate initiative, and there usually isn't coordination between what the community has already said they need, what are clearly community priorities, and then what medical education is doing. And making that connection, I think, is extremely vital, especially if we're going to tackle racism in medical education. Next slide. And to round it out, if you're following along, this is E10, which is promoting social justice and engaging in efforts to eliminate healthcare disparities. Next slide, please. So I'm encouraged by the students I see in the room, if you could go to the next slide, that this effort to remove race in the GFR in particular and in other rule-based algorithms in our nation has largely been led by our students. Our students get fired up about it. They're asking our faculty members what they can do. They're part of committees. And the power of the student voice is really came relevant or when in the last couple of years. And this is an article that AAMC News put together. But I was encouraged to hear that students said enough is enough. And they wanted to get involved. I think this is something that we have to remind both our learners and our faculty that this is a nationwide crisis, that racism is embedded in every aspect of medical education and academic medicine. And as many of you here have been part of this fight to remove race from several of these algorithms, to continue doing so. Next slide, please. This is a reminder for many of the students who are in here who want to be more of an advocate, who want to advocate on the federal or state level, that we do have this guiding principles for medical students. Next slide. And before I close, I wanted to bring this up because oftentimes I hear conversations about these algorithms that say, I didn't create the algorithm, and I'm not messing with this artificial intelligence. I'm not sure what's happening there. If a algorithm comes on my screen in the electronic health record, someone else made that decision. That's the administrator's job. But this was proposed from the Office of Civil Rights that says that we as clinicians can be liable for the algorithms that we use, for any discrimination that if we decide to use some of these algorithms. Now, this hasn't gone through yet, but actually it already states that we cannot discriminate in our clinical care. But they wanted to make it even clearer by adding this special provision. And I just want to read this, that while covered entities are not liable for clinical algorithms that they did not develop, they, and they as in clinicians, may be held liable under this provision for the decisions made in reliance on clinical algorithms. So I hope that this gives us a reason to pause for a bit. We may not be research scientists. We may not understand all of the different elements of some of these algorithms, but we can be held liable. And I think that's why we all have to come together to be a part of the solution and to dismantle racism, even in what may be a difficult part of medical education and academic medicine. And next slide, please. So I'm going to give you one more homework assignment, and that is to look at just these four and maybe the other ones that you've pulled up on your phone. And what can you walk out of here today? Will it be to advocate for diversity and make sure that we are represented, that there are voices from every community, both your local community as well as those who are minoritized in this nation, who are making these decisions in medical education and healthcare? Is it to make sure that all of your quality improvement projects are stratifying by race, ethnicity, that you're hearing the community voice, or you're promoting social justice, and you're advocating both at a local level, a state level, and a federal level? The next slide, I'm just going to remind you, because I saw the abstracts, that you all have a lot of information. You have done a lot of great work, and we hope that you can submit to this continuum that this compendium that we're putting together at the AAMC. We don't want these competencies to just exist on their own. We want to share your curriculum with all the medical schools in our nation. So all those abstracts I hope to see submitted in this compendium. And if you want them to be peer reviewed, if you go to the next slide, please consider submitting them to MedEd Portal. We have an anti-racism in medicine collection as well. And I believe this is my last slide. If you can go to the next one. So these are a few more resources that we have at AAMC with podcasts, our Ideas Learning Series, which is a monthly webinar on inclusion, diversity, equity, and anti-racism, as well as a website that features a lot of your work on anti-racism resources. The next slide is my contact information. Catrice and I are here today. We want to hear from you. We want to learn from you today. And I appreciate you all listening. Thank you.
Amazing. Thank you so much. Now we're going to spend about 10 minutes for a Q&A. So if anybody has a question, I think I can probably use one of these. Who has a question? Yeah. You got it?
I can run between. Thank you so much, Dr. Fair, for that talk. I think I really appreciate it. My name is Cameron Clark. I'm a medical student at Columbia University, and I've been involved with White Coats for Black Lives and a couple of other organizations over there. I think one of the slides brought up something that I've been sort of struggling with as a medical student, because I think there's been sort of like a theme of trying to move away from the acknowledgement of race in the one-liner and some of the patient records that we're taking. But I think it's something that I've been struggling with, because I think, to your point, if we're not tracking something, we're not really able to do an effective analysis of, when that thing is impacting patient care. I think you mentioned about how, Black patients were facing longer times towards scans and further, like more tertiary level care when they're entering into the emergency department. I think I was wondering about your perspective of like, when is an appropriate time to incorporate race into the electronic medical record versus when is a time when it would introduce more bias to the patient experience. So I think I wanted to hear that from you.
That's an excellent question. I wish I had a really pithy answer. I will answer it this way. So I gave a talk probably maybe about a year ago, and someone challenged me and they said, Dr. Fair, you're telling me not to use race in my algorithms, but then the next slide you're saying you got to use race so you can look to make sure there's no inequities, which is something I feel like I'm hearing from your question. And I said yes, actually I am saying that, because I think there's no easy answer here. If we just remove race, then we know that the bias already exists. We know that structural racism is very much alive and well, and we will just continue doing what we've always been doing and just kind of eliminate things. But then if we talk about race all the time, then we may be introducing bias. My recommendation is this, especially with the one-liners, that if we are going to use race in our clinical vignettes, then we have to acknowledge our bias right up front. Right? And then we have to have a statement that also says, even though I've just mentioned the race and ethnicity of this patient, let's all consider our collective bias as we are taking care of this patient, which is what we did not do in my very first story. On the flip side, I think we have to include race in all of our quality improvement projects because it's our check and balance. It has to be in the electronic medical record because that's how we identify whether we are missing something or that we're not even thinking about. So I don't think you can eliminate it altogether, but I think we have to keep talking about it and acknowledge our bias the way in every step. I hope that answers your question.
Thank you.
Thank you. Hi, Dr. Fair. It's good to see you. We go way back from medical students. So I was so excited when I heard about the AAMC DI competencies, and actually I think I may have reviewed some version of them. And I'm wondering, what has the response been from medical schools? And then also, how are you going to incentivize medical schools to utilize the competencies? Because that is really the challenge, right? They're there, right? But how are we going to, what's the incentive going to be for them to use it?
Great. So great question. So here's the challenge with the competencies, and I think many of you know, and that's embedded in your question, Dr. Blackstock, so great to see you, is that we at the AAMC are not prescriptive about what we are asking our medical students to do and medical schools to do. That part is the LCME, and we can't mandate that every institution takes these competencies. What we do hope, and that's part of why we have the compendium here, is that when there are great examples of ways that you can incorporate the competencies into your curriculum and it's plug and play, and I say, okay, Dr. Hess has created something amazing, I'm going to take that, download it, and use it in my institution, then that will promote this uptake. It is difficult to develop your own curriculum, but we hope that with this shared community, with communities of practices that are being developed, that people will want to adopt them. We also know that money helps. So we have a grant program at the AAMC that's run by Catrice Kane, our AAMC Next grant, that we'll be announcing the winners. And that is also a program where we've supported institutions who are doing work around anti-racism, and we hope to continue to offer funding that way to your institutions to do that. But there's no easy solution here. We don't think that tomorrow 100% of our institutions are going to use it, but we hope through funding, healthy competition, and collaboration that we can get more institutions to not only adopt, but to modify, to incorporate, to integrate within their curriculum.
Sorry, thank you.
Hi, my name is Sophia Castellanets. I'm currently at One Brooklyn Health, serving as a health equity lead. My question is around power. I think a lot of our trainees here, we're in a hierarchy, and folks feel that they may not have the power. And yet we've seen across the country that that's not true as we start to see some of these equity movements. So would love to hear kind of your highlights on how folks in this room, particularly our trainees, do have the power to create the change that we're seeking.
Thanks for bringing that up. I think I, as a medical student, did not feel that power. You know, I wrote my checks to AAMC to get ARS and AMCAS. I showed up and and passed my exams and just hoped to get into a residency. But now, in this position at AAMC, and even as a faculty member, I recognize that what I did not see, that medical students and residents have a lot of power because you're in a different position. One, you're paying tuition, but two, you're brand new to the healthcare field. And when students come together, that student voice can be really powerful to change administration. And we saw this, and I think one of the medical students mentioned they're part of White Coats for Black Lives. Let's acknowledge the ripple effect that White Coats for Black Lives made across medical schools in this nation. There are a lot of people who weren't happy with the report card, but it got a lot of people talking. Let's go back to 2020 when several medical students created demand letters from their institutions and say, we have to have statements. We've got to have new committees. Now we're having some backlash now where a lot of our institutions can't do the DE&I work that they could do before, but those letters were coming from students and the deans were listening and they came to the AAMC and said, help us out. Our students are not going to be, are not acceptable. They are not going to be okay with the status quo. So I just want to remind the students in the room that you do have a voice, that your deans are listening, even if you don't think so, because they're coming to us asking for help, and to keep talking, keep advocating. And we want to hear it too. So if there's something that we can help with, we want to hear that too at the AAMC.
We have time for one more question.
Thank you so much, Dr. Fair. My name is Shravya. I use they and she pronouns, and I'm a medical student at Columbia as well. I'm curious, one of the points that you mentioned was the importance of community integration. And as a first-year medical student, I heard over and over again that I'm at the closest I'll ever be to my community members. And as I advance my medical career, I'll get closer and closer to the medical community and leave the community behind, like the community I came from. And I'm curious as to what it would take to have more sustainable integration of community members into these conversations. I think we're so used to the hierarchy of academia and the hierarchy of policy and things like that. And I'm curious as to what sustainable integration into healthcare would look like. So
I think I'm going to answer that two ways. One is, again, another homework assignment to Google Consuelo Wilkins at, and I'm blanking on, it's Vanderbilt, thank you. Vanderbilt and Meharry. She has a really great model of not waiting to the very end and involving community voice. And so she has and not just her, but her whole department, they're called community engagement studios, where community members are involved in asking the questions before the research is even started. They're helping to decide what's the right patient population, what are the questions that need to be asked, how do you integrate community members into the research study? And I feel like that's an underutilized model in academic medicine because we just wait till we get the grant funding. We wait and we give our gift cards and we feel really good about that. So I hope to see more examples of that in academic medicine. And the other thing I would hope to see is just like in our medical schools and in our hospitals, you're beginning to see some learner participation on committees. There'll be that one student that's part of the patient satisfaction committee or one student that's part of the DE&I committee. I don't see a lot of community voice or patient voice on those hospital committees, and I almost never see community voice on medical school committees. And I hope that that could be a policy change, that we don't just say we've got to have a medical student here, but we say we have to have a patient who will experience care from our students, who can contribute to decisions that are being made at our institution.
Thank you so much, Dr.
Thank you all.